Here we're going to be looking at drugs for treating dermatological conditions. So we'll be going through and again reviewing some pathologies that we looked at in the clinical pathology book. So we'll be reviewing some of that, and obviously in addition to that, expanding upon the treatments and looking at the various things. So particularly here we'll be looking at a lot of topical medications, which we haven't discussed too much in depth up until now. We've kind of made some mention of them, but obviously a lot of what we'll be talking about too will be coming back to some drugs used for treating infections, due to the fact that some of the dermatological conditions we've talked about are caused by infectious organisms, and are caused by bacteria, viruses, and fungi. So we'll be discussing that throughout this discussion. So looking at various pharmacological vehicles of skincare, and we're going to be, many of the medications are going to have different ways of basically delivering various types of topical treatments to the skin. But first, when we just, again, we've done a pretty extensive look at skin pathology in the pathology chapter, but and the reading in this chapter does tend to reinforce a lot of that. So we basically look at, when we're looking at skin pathology, we're dealing with either an injury infectious type pathology or autoimmune responses. So the injury or infection can basically is disrupting kind of the natural antimicrobial properties of the skin, and then the autoimmune responses, particularly to antigens and various things that kind of disrupt that anti-inflammatory property of the skin. So again, ideally what we're looking to do is, you know, our skin basically does function as part of our immune system. It basically has antimicrobial properties to it. However, injury to the skin, or some type of, in the case of the autoimmune responses, the antigens can potentially upset or kind of cause immune dysregulation that damages that epidermal structure. So we all know the different layers of the skin, and the fact that, you know, the cells on the surface of the skin are constantly getting turnover. Again, that's something that you can go back and look at with the pathology. But again, we're looking to basically protect the dermis from various factors. And again, those epidermal cells ideally can do that. However, again, if that somehow gets disrupted due to injury, you know, bacterial, viral, fungal infection, or autoimmune responses. So that kind of looks at the various things that could kind of cause disruption of the skin. And then we have our common pharmacological vehicles, or basically ways to sort of deliver treatment to the skin topically. Again, and we're also within the chapter going to be discussing like oral medications and things that we may at times need systemically. So this is just a list, and I'm going to make some general mention about the various types of sort of delivery systems, if you will. However, when you're looking at the descriptions, and I'm going to guide you to look at the descriptions in the book on these, again, they're going to be used a lot of the times. The delivery method will be kind of based obviously on the type of pathology. For instance, if you have a pathology that is, you know, you tend to have like pathologies that produce a lot of like moisture with the skin condition, you tend to favor things that tend to dry them out. And then vice versa with you know, skin pathologies that produce dryness, you tend to moisturize them. So that's something to keep in mind kind of as you're going through this. So certainly look at the descriptions of all of these, and be aware of what their, you know, primary vehicle is for delivery of the medication. So looking at some skin dressings. So obviously, as we know, when there's superficial trauma to the skin, there's various dressings, coverings that could be utilized. So to discuss some of them here, you have some of your, you know, what we call time-honored practices, or things that have been used in the past that are still effective, but we'll talk about some more contemporary approaches as well. So just regular gauze pads, which many of us use. So, you know, Telfin non-adherent dressings are one example. These are just used for a lot of your general superficial skin lesions. Then you have wet-dry dressings, or what most people tend to prefer, a wet to moist. So in the case of a wet to dry or wet to moist dressing, what effectively do is you will You will wet a typical non-occlusive dressing. So basically take a gauze pad of some sort and you'll moisten it with saline and you'll put it on the wound or the traumatized area. You'll let the saline evaporate. And again, this is where, and again, sometimes the debate is if you allow it to go completely dry, you can cause additional trauma when you go to pull it off. So that's why a lot of people prefer the wet to moist. And that's basically what you'd use to debride the wound. Again, there's research out there as far as when this is good, bad. For our purposes, we're just making ourselves aware of the type of treatment. Now, the more contemporary modes are what a lot of people like to use. So these are various types of dressings that kind of work to kind of optimize the healing of the area. So occlusive film dressings, so these are just various types of what we'd call transparent films that can help seal off the wound and kind of increase the absorption of some type of topical therapy. So for instance, if somebody's using a topical corticosteroid over something, it actually helps to increase the absorption of it. In the case of a wound, it could also help just heal with various types of open wounds and skin burns. So bioocclusive is a very common type of occlusive film dressing that gets used. There's various types of foams, so various types of spray foams that can be utilized, or even continuous, what we call film dressings that kind of function in the same way as foams, that could get utilized over various types of superficial and partial thickness openings in the skin. There's hydrocolloid dressings and hydrogel dressings. These specifically will work to draw fluid out of the skin. Again, these are usually applied with some sort of gauze cover. So, the book gives some examples. Tegaderm is a very popular one. Duoderm is another. And again, these can be used in patients. These are particularly very useful with cutaneous ulcerations. But again, they could be utilized for any type of trauma to the skin, full thickness skin trauma, and post-operative incisions. Dermal adhesives, these help with wound closure. So these are things like your Steri strips, Dermabond skin glue, which is very popular. Again, these are used for partial, full thickness lacerations, trauma to the skin, post-operative incisions, anywhere you have, and they're very effective, particularly in areas where you have a lot of lower tension on the skin. So obviously, if you have a fairly big laceration to the skin and it's in an area of high tension, that's where something like sutures are going to be a little bit more appropriate. But dermal adhesives can certainly be utilized in those circumstances. And then just to make note, as far as like some clinical applications, you talk about treating keloids or removing keloids. So keloids are basically hypertrophic scars. They differ from your typical scars that you get that mature on the skin, or whether that's from trauma or surgical incisions. They're more common in African Americans. They do tend to get keloids at a greater rate, and they do occur typically in younger individuals. So again, you have two treatment options for them. Injections with different types of medications, as we have posted here. They're very successful in reducing keloids. Your non-invasives, many times like topical silicone gels, are safe as far as treating that. So a small thin layer of that, which is self-drying, can be applied. And that can be applied by an athletic trainer. Just helps to increase hydration of the stratum corneum, which is part of the skin, and protects the scar tissue from infection, and looks to kind of balance that out. So those are kind of your two options as it relates to dealing with keloids. So looking at the various topical agents. So first, we just look at just general topical agents as it relates to kind of cleaning the skin. So again, we could just look at this even from like a wound care standpoint, kind of what we look to use. So again, simple soap and water and saline to clean skin is very effective. And again, part of the benefit of that is that it doesn't introduce trauma to the skin or to the healing process. So both of those are very good for kind of cleaning that out. Many times a lot of your solvents that you might use to clean wounds and things like that, they can be very irritating, and they could actually sort of slow down the healing process a bit. They could also cause things like allergic dermatitis. So, for most wounds, trauma to the skin that need to be cleaned, soap and water, just a potable tap water or an isotonic saline solution is usually very effective for that. Again, because it'll cleanse the area and not cause additional trauma to the skin. Emollients tend to help in restoring the skin and the moisture to the skin. This helps maintain hydration. So topical agents will generally contain some type of emollient with their delivery. And again, so this will be things when we're looking to moisturize the skin. So moisturizers also tend to work when the skin is already moistened. So if they get applied, for instance, after a shower, that tends to be enhanced. So if you have a skin condition, or even if you're just dealing with dry skin, applying a moisturizer after a shower or something like that, that helps in delivering that. Then there's various types of emulsifying agents that can be utilized in helping to moisturize the skin. Some moisturizers will also contain a keratolinic, which can be used to kind of like, for instance, break down like calloused skin. And that can help in kind of breaking down that hardened calloused skin as well. Drying agents can be utilized in situations where excessive moisture can cause areas. So we also look at this being particularly in areas where in skin folds between the fingers and toes, many times in those intertiginous areas, many times if moisture builds up, you could get maceration of the skin. So drying agents tend to work very well to kind of help heal if something is caused by sort of like a moisture problem. So medicated powders can assist with that as well. Miconazole can be used to treat fungal infections. You typically see that in like a lot of like foot powders, and when you start to deal with things like tinea pedis. So there's a whole list of medicated powders. This is just one example. Clotrimazole is another one. Tonophenate is another one. So those are various types of things, particularly for both preventing and treating fungal infections, that can be utilized. Your textbook talks about like cornstarch and talc. Talc can be very effective, but it can cause granulomas if it's inhaled. And that's actually not even used in baby powders anymore. Cornstarch can be effective, but it can promote fungal growth. So you have to kind of look at what type of powders you're using whenever you're trying to treat something caused by moisture. So various types of skin and soft tissue infections are things, and we've kind of already talked about them in the pathology chapter. So again, they represent kind of a unique challenge, and in particular in athletic settings, which a lot of people will be kind of working in obviously through and as an athletic trainer. So again, we look at the various types of infectious organisms. So typically the type of treatment that you're going to utilize will be based upon what type of bacteria is causing it. So as we've already discussed, there's streptococcus, staphylococcus infections, and again, the big one we always want to be concerned about is MRSA, and that's because obviously in order to treat that, you have to watch what type of antibiotic you use on that, because it's going to be resistant to certain classes of antibiotic. So these are some of the bacterial infections that we're going to expand upon as well. So impetigo and ecthyma, which is a type of impetigo, and then we have your other types of bacterial related infections, your folliculitis, furuncles, and carbuncles. One thing to be aware of is when you look at bacteremia or systemic inflammatory response syndrome. So if the patient does start to show signs and symptoms of systemic toxicity, which is going to be a red flag issue you want to look at. So in the textbook, they give the red flags. So elevated body temperature, elevated breathing, heart rate, even to the point it could extend into delirium. You start to see more extensive soft tissue damage. Those are all things you need to be aware of in the case that somebody does have a a bacterial infection that does start to spread. Septic shock is also something that could come out of that as well. So just important to monitor the bacterial infection. And again, in those situations, you may require more extensive treatment, whether that involves drainage and or oral antibiotics in order to manage that. So looking at our topical antibiotic agents, so again, all of these antibiotic agents are going to help reduce a wide variety of types of infections. So we're both here just initially going to look at this from both a standpoint of obviously treating bacterial related infections or even preventing infections in open wounds. So we look at this kind of wide range of application, in infectious conditions like things like impetigo and acne vulgaris. So for instance, in acne vulgaris, there's topical antibiotics like clindamycin that can be used if patients don't want to take an oral antibiotic. With something like impetigo, which we've already talked about in the pathology chapter and we'll discuss later on, mupirocin or Bactroban is a very common treatment for that. And again, it gets commonly used for those particular types of infections. When we look at treating like wounds, for instance, a lot of topical antibiotics can reduce the infection rate among many types of skin conditions. So your topical antibiotics like bacitracin, polymyxin B, in some instances, those have been replaced. So many times people are now using topical petroleum for post-operative care of like skin biopsies to prevent infections, and even in things like various types of just like minor scrapes and burns. That's been used. The NATA position statement has put a position statement out of common topical preparations that help to reduce infection rates in acute skin trauma. So most specifically, an over-the-counter triple antibiotic, which contains neomycin, bacitracin, and polymyxin B, which gets supported by the NATA position statement. So that's a common thing that tends to get utilized. So prescription-wise, again, your topical antibiotics, you have mupirocin, clindamycin, and ribapamilin. And again, they kind of go over the dosing. So if you look at table 16.3, they talk about the dosing for them. Again, there's no difference in infection rates via these modes of treatments. You do want to be aware, and that's why it's important to know kind of like the dosing schedules. You don't want to excessively use them because they could potentially impede wound healing. The other thing that they could potentially promote is antibiotic resistance. So you want to make sure that you're only using the prescribed dosage amount. Again, all of the particular medications that we're talking about, whether it's like an over-the-counter triple antibiotic or neosporin type of medication, or your prescription preparations, it's very important to know your dosing schedule and how they should be used to optimize their use without having side effects. So getting into our specific bacterial infections that we're going to be discussing in this chapter, and again, this could kind of coincide with the pathology chapter, and many of these we've already talked about. So MRSA, or methicillin-resistant Staphylococcus aureus, just as in general, you'll just hear people talk about like someone got a staph infection. Usually what they're looking at, and again, this is a specific type of staph infection that's resistant to penicillin. So penicillin and anything within the kind of extended penicillin family, this particular infection is resistant to this. And many times what it'll do is they commonly confuse this with spider bites. So they'll say, oh, it kind of looks like a spider bite. So you should, if you're seeing this, you should consider, particularly if you're seeing like, multiple spider bites, you should be considered a possible sign for a community-associated MRSA. So again, it's going to be resistant to various types of antibiotics. So when we're looking at the recommended antibiotics that are normally for most skin infections, that will typically not work for this. So that's why the proper recognition of this is going to be so pertinent because there's particular drugs that will need to be utilized. So we want to make sure, and anyone who maintains close contacts with individuals should be kind of watching for potential the spread of potential infection. So particular drugs used for treating MRSA. So again, given the potential for rapid development of resistance, there's some antimicrobial agents that are discouraged for this. So your fluoroquinolones and your macrolides are going to be discouraged against using. So the common ones that will typically get utilized, so patients with this for the treatment, your oral antibiotic options should include the following. So clindamycin will be utilized. Bactrim or Septra could be utilized as well. Vabromycin is another one. Linezolid or Zyvox is another one that your textbook talks about. You want to avoid fluoroquinolones and macrolides, as I talked about, so you will not be using those. Azolides or another type that you'll be looking to avoid as well. So again, due to the communicable nature of this infection, patients with active lesions can't participate. So there should be no sports, no contact sports with active lesions. And an AT should monitor an affected athlete until they've completed an antibiotic course for greater than 72 hours. So 72 hours or longer of treatment is going to be needed for the individual. And again, you want to monitor in general just to make sure that what's being used to treat the infection is being effective and that the infection is not continuing to spread. Non-purulent and purulent bacterial skin infections. So your classification here, so your non-purulent infection, we look at impetigo and eczema. Basically, they're the same thing. So impetigo, as we already know, it's that contagious skin infection. We talked about it in the pathology class. It's characterized by that typical honey-colored crust, usually either caused by a streptococci infection or staph or even both. It occurs usually warm, humid conditions, spread very easily. Eczema, which we did not talk about, is the ulcerative form of impetigo. So it's still impetigo, but it presents a little differently. So basically, you still get some painful pus fluid-filled sores. And usually what they'll happen is they'll go a little bit deeper. So eczema kind of, again, it's the ulcerative form. It goes deeper into the dermis. Many times individuals will have swollen lymph nodes because of this, because of the infection going deeper. Both of them will cause some discomfort and itching. And again, it's important for people to avoid contact. So they do recommend cultures to identify the type of bacteria that could kind of help in sort of focusing the antibiotic treatment on it. Penicillin is definitely a viable treatment form here. Erythromycin, clindamycin, if someone has allergies to penicillin. And again, if possible, you can use topical prescription antibiotics. So they do prefer that. So clinical experience suggests that systemic therapy is preferred, particularly if you have numerous lesions or if the outbreaks affecting several people to decrease transmission of infection. However, if need be, you can consider topical prescription antibiotics for more kind of contained infections. Your purulent infections that we're looking at, so folliculitis, furuncles, and carbuncles. So folliculitis is just that purulent infection caused by infection of the hair follicles. Again, kind of the characteristic sign and symptom of that is you just look for those little fluid or pus-filled sacs at the base of hair follicles. And then as you kind of go along here, they represent sort of deeper and more serious infections, I guess, for the most part. So like furuncles or boils, they're a little bit deeper into the hair follicle. Carbuncles is kind of when you basically get a bunch of furuncles and they're kind of all joined together and they kind of form sort of a bigger, larger area of infection. So again, depending upon the situation, you may possibly need a higher level of care for these infections. Or it could be even just as simple as a warm compress. So like for a simple furuncle or a small area of an infected hair follicle, a warm compress may be something that's enough to kind of treat it. So it really just kind of depends on the severity of the infection. So like I said, even a furuncle, you may just need a warm compress. A more fluctuant furuncle or even a carbuncle might require incision and drainage. Okay, most cases a topical antibiotic may be good, and many times even just an over-the-counter topical antibiotic can work. So mupirocin, or what's also known as Bactroban, or even a triple antibiotic like a Neosporin, which again will have neomycin, polymyxin B, and bacitracin in it, can even sometimes be sufficient for this. Systemic antibiotics are usually not needed for this, again, unless you have, evidence of like a systemic infection. So if someone has, a purulent infection, they're starting to show some signs of systemic infection. In many cases there you will potentially prescribe, or a physician will potentially prescribe an antibiotic. You do just want to monitor them. Anytime you have any type of purulent skin infection, you want to just monitor for MRSA. So you want to make sure that the reddening around the area is not starting to expand, that there's not further growth, that there's not any signs of systemic infection. Abscesses. So abscesses are another bacterial infection. So when we look at an abscess in general, first before we get into the treatment, so basically an abscess is just a pus collection in the dermis and deeper tissue. So what you'll find is typically like a painful, tender, red area, nodule. There could be some pustules around it, but basically what's happening is deeper into the skin, there's going to be this big collection of pus. Again, as far as treatment is concerned, usually they will have to do an incision treatment to drain the abscess. You can also cover the site with a dry dressing. Typically, oral antibiotics might be needed with this. So they're, depending on the how widespread the infection is. So, and again, depending on the type of infection, so many times like a Staphylococcus aureus infection can cause like a large percentage of a lot of your skin abscesses, and that could be a much larger infection. So really important that you're able to kind of identify this as it's forming and refer to see if there does need to be incision and drainage. So monitor for MRSA again, and make sure that it's starting to heal. Again, some of the drugs that you'll be utilizing for this, you may have to incorporate a systemic antibiotic if they do start to show signs of that systemic inflammatory response that we discussed earlier. The AT may be you as the athletic trainer may be in charge of closing the wound or packing it with gauze, potentially in conjunction with the care that the physician would be in communication with. Fungal skin infections, very common in sports medicine settings. So your fungal skin infections are going to be caused by what are called dermatophytes. Those are just fungal organisms that essentially on human skin, they could survive on the dead keratin in the stratum corneum of the epidermis. There's many different species of fungi that can cause this, and as we commonly know it as ringworm. And ringworm is basically going to be classified based on the area of the body that it infects. Typically, whenever you're looking at a topical treatment, and in table 16.4 in your text, they talk about various topical and systemic agents for treating fungal infections. Topically, you need to treat the area usually for about 2 to 4 weeks, regardless. And many times, again, it's important to encourage your patients that even if it looks like the infection is gone, to continue treating the area. So many times patients will start to see the area start to heal before that time frame. They have to continue to keep treating it. So The chart in that book will tell you which ones are over the counter, which ones are prescription. The over the counter do tend to be very effective. In the case of certain types of ringworm, so for instance, any infection in the scalp, the nails, they tend to work a little bit better with the systemic antifungals, just because they're very difficult to treat with the topical antifungals. And again, so the oral antifungals, they are going to be represented with the suffix azole. So that'll kind of let you know, that give you a hint that that's going to be an antifungal medication. So Tinea capitis. So again, you can do it with a topical. Sometimes the oral works a little bit better, just because the topical could be a little tricky sometimes on the head. Many times you can get a lot of gray scaly patches that could cause hair loss with this. So you have to get treatments for at least 2 weeks to be considered infection free. So that's an important thing to note. Tinea corporis or Tinea caruris. Okay, so Tinea caruris is also known as jock itch. Tinea corporis is commonly what we think of with ringworm, so various areas of the body. So common brands that are usually used to treat them: Lamisil, Lotrimin, Nizorol, which are some of the different types. Lamisil and Lotrimin are available over the counter. And then Tinea pedis, many times individuals use antifungals plus a talcum powder. Sometimes they could come in powder form. Individuals will sometimes use those as even like a preventative measure to prevent getting that in individuals who are active. So it's important to note the kind of the different types and what we look at as far as the overall treatment that we're looking at. Again, as far as participation in sports, particularly for Tinea corporis, you have to have at least 72 hours of treatment prior to being allowed to go back, particularly when you look at, like, obviously sports like wrestling. That becomes very important. And again, make sure that the individual still continues to treat the area even after the infection appears to be healed. So Candida is a ubiquitous yeast that basically does reside naturally on the skin. However, there's basically things that could kind of trigger it to sort of grow sort of in an uncontrolled manner. Usually when you look at, again, damp, heat, impaired local and systemic defenses, so people who are immunocompromised, that kind of allows Candida to grow, and you end up with a candidiasis infection. And it's a yeast infection. You'll hear people kind of lump it in with fungal infections, but more specifically, it is a yeast infection. We've kind of talked about when this happens in the oral mucosa, it's known as thrush. But again, this could present in many different areas. So kind of throughout the body and on the skin, it can also grow. So you should consider candidiasis in any time an individual has erythematous reddening of the skin, scaling, pruritic patches, particularly in intertriginous areas, which are like between folds of the skin or in between the fingers. You should consider a candidiasis infection when you're looking at that. It is resistant to multiple types of antifungals. So Lotrimin and mycostatin are usually what are the common things used to treat this. So clotrimazole, which is also Lotrimin, and then nystatin, which is mycostatin, those are commonly utilized for that. Sometimes, in certain cases, a prescription or even possibly a systemic antifungal may be utilized for this. In the case of oral candidiasis, that many times gets treated by dissolving a clotrimazole lozenge in the mouth. So they'll dissolve that lozenge in the mouth 4 to 5 times a day for 14 days. If they have a chronic, anytime there's a chronic candidiasis infection, you might require more long-term oral antifungal treatment. Fluconazole or diflucan may be needed in those circumstances. So now looking at some viral infections. So again, we've talked about the pathology of these already, but again, just to review quickly, so your herpes simplex, molluscum contagiosum, Again, skin-to-skin contact is where many times this is going to be transmitted. Kind of your hallmark signs. So as I discussed in the pathology section, again, being aware of the types of lesions can really help with this. So again, herpes simplex, it's going to be categorized sort of based upon the area of the body it shows up in, but regardless, you're basically getting those little clusters of vesicles on the erythematous base that forms in the area. So that's kind of the hallmark sign of that. The treatment very commonly for this is acyclovir or valacyclovir. So your antiviral medications, you're only going to use an antibiotic if there is a concurrent bacterial infection that forms because of the compromised area of the skin. So the antibiotic obviously is not going to have any effect on the actual virus itself. However, because the continuity of the skin gets compromised because of the lesions that form, there is the potential that there could be a bacterial infection that does form. But your antiviral meds are going to be is kind of your hallmark treatment for this. Again, herpes gladiatorum, very common in wrestlers. Again, the treatment is going to be antiviral. Again, the NCAA has specific rules, and I'm going to want you to kind of know what those requirements are. So again, just to kind of review that, again, the wrestlers have to be asymptomatic, so they can't have those systemic symptoms that come about with herpes infections, and can come about even with recurrent infections. No new lesions for 3 days. The lesions have to be crusted over. They can't be, kind of wet and weeping. And they have to show proof that they're on antiviral meds for at least 5 days. So, and many times wrestlers will just, if a wrestler has had an infection in the past, many times, they'll just get from their physician kind of like an open-ended prescription of this, because so they can start taking it right away if they kind of know that they're having a reoccurrence of the infection. The molluscum contagiosum, this is another highly infectious viral infection. So this is something that could go on for a while. So they may need to be more prolonged treatment. And, when you're talking about, particularly with athletes, and again, we just always come back to wrestling for this, because this is, where all that tends to be the biggest issue. You're probably going to have surgical intervention. So you're going to probably have to have the lesions removed, because if you're waiting for them to heal, it's going to take a really long time to do so. So many times individuals in contact sports will just go get them removed, because that's going to be pretty much the fastest way to help return back to activity as quickly as you can. Because if you wait for it to heal, you could be waiting a really long time. They cannot, wrestlers cannot wrestle with active lesions. They will need to be removed before returning to sport. So now turning to inflammatory skin conditions. So again, these are going to be a variety of conditions with many different pathologies. Kind of looking at this, and these for the most part are just self-limiting. So there's they're not contagious, but they're things that are obviously uncomfortable for people that have them, because it causes a lot of disruption on the skin. Pruritus is something that tends to come with a lot of these inflammatory conditions, so they're kind of uncomfortable, and they can be pretty widespread. So some are going to require a little bit, maybe even higher level of treatment, depending upon what the cause is, and many times you look at autoimmune diseases kind of being the result of this. So there's many autoimmune diseases that kind of cause that inflammatory reaction on the skin. If that's the case, you should not be using an oral antibiotic for those if they do occur, because of the issues with the autoimmune disease. So, and they're not really going to be helpful for it. So your therapies for many of these, and again, it kind of really depends on what you're looking at, what the person's kind of dealing with. Corticosteroids, again, whether topical or systemic, and again, we know that there's the potential complications for those. Even topical corticosteroids, they can get absorbed systemically and possibly cause adrenal suppression. So you have to make sure you're looking at how long you're using these for. And again, with any of these corticosteroids, if you're starting to use them for longer than a month, you tend to get there tends to be the greater chance for having negative side effects. I'm just going to name some popular versions here. So Cordate or Cortisone 5 are very popular corticosteroids. This is probably one of the biggest things, a treatment for pruritus. So again, topical corticosteroids can be used to reduce itching. Various lotions and creams can be utilized for that. So again, some options. You can possibly use either just an oral prednisone, possibly some other systemic antihistamines can be utilized, or just even basic calamine lotion. So calamine lotion is just used for various things on the skin that cause itching, and it's just a combination of zinc oxide and ferric oxide. Most people just use calamine lotion for various skin conditions that cause itching. And then specific treatment for urticaria or hives, again, your antihistamines, so Claritin or Benadryl tend to work really good. Possibly, if need be, you may use a systemic corticosteroid if it's very widespread. Obviously, if angioedema is present due to some type of allergic reaction that's causing it, you would want to have an EpiPen for those purposes. So again, things involving just general inflammation of the skin, so dermatitis. The biggest thing with dermatitis is finding the cause. So that's usually the biggest challenge at hand, is finding out what's causing the dermatitis. So again, has someone changed soaps, detergents? Make sure to look at that. But for the most part, if you're just looking at a simple dermatitis, you're just basically looking to treat the symptoms, because the way to effectively get rid of it is try to remove the cause. Now, again, that can be challenging at times, but you can certainly do it. Over-the-counter topical corticosteroids or soaks work really well. Prescription-wise, some non-sedating antihistamines are very popular, and even they're not all prescription. You could also get some of those over the counter. For atopic dermatitis, again, it's just symptomatic treatment. They recommend avoiding oral corticosteroids with atopic dermatitis, just to again reduce those chances of systemic issues kind of associated with that. So when looking at atopic dermatitis and eczema, again, that's a chronic inflammatory disease. So you're basically looking to, as a goal, is restoring that epidermal barrier function. So again, with atopic dermatitis and eczema, you're getting a significant kind of breakdown of that epidermis. Remember, we said that epidermis is really kind of what prevents infection and things like that. Once that epidermis gets compromised, then that kind of, again, and many times with eczema, that's one of the biggest things. The skin gets so dry and compromised, and then on top of the fact, people are scratching because they have significant pruritus, that breaks down the skin even further. So your treatment goal is to kind of restore that. And then, many times you get symptomatic treatment with emollients, because you're trying to basically moisturize the area. Again, in these circumstances, you could avoid oral corticosteroids for these conditions. If you are going to use corticosteroids, they can be utilized topically. And then psoriasis. So psoriasis is kind of one of the conditions that kind of stands out with this, and you have these very distinct patches found in various places. We had talked about the lesions related to psoriasis. And again, for psoriasis, there's various OTC and prescription options. So again, many times with psoriasis, you look at topical corticosteroids. So any of the topical corticosteroids that get mentioned within the reading, or that we've mentioned in the past. Vitamin D analogs, again, emollients, just to kind of help with moisturizing the area. Even things like coal tar has been recommended. And, from a prescription standpoint, your immunomodulatory agents, because we do know that there's an immune system issue when we're looking at individuals that have psoriasis. So in summary, to kind of tie this up again, there's a variety, and probably one of the more challenging things for athletic trainers clinically is being able to recognize skin conditions. And but it is a really important part of what we do, obviously because of the fact in athletic settings, a lot of close contact and contact sports, so a lot of these things being spread skin to skin, especially if you're in wrestling. It's not a surprise that most athletic trainers that work a lot of wrestling tend to be very, very well versed in skin conditions. So again, look at your pathology related to this. We did cover a little bit of that here. Again, understanding what the skin does. Again, the skin is basically a protective. It does function as basically a part of our immune system to a degree because it does protect the body. However, once it gets compromised, then that obviously lenses to various types of infections. So be aware of those dermatologic conditions. We talked about various ones throughout the discussion in pathology. And again, being aware of them and how they affect the competitive athlete. So again, the biggest thing is number one, stopping the spread of infection. So regardless of what it is, understanding what an athlete can and can't compete with, and how long they need to be treated for certain conditions before they are allowed to return to activity. And then we have our objectives. So again, just like everything else, again, be aware of the different types of medications. Refer to the charts and tables in the book. They will also kind of help with the dosing. So again, you can add those into your notes as you see fit.